Hi, and welcome to session 2 of the Redetermination Community of Practice. We have lots of material to share with you today, so as folks start to log on, we are going to get started. I want to first provide a frame for this community of practice. This COP is focused on HR1 as it relates to redeterminations. So there are several other policy changes coming out of HR1 that will impact access to Medicaid. So things like increased copays, loss of coverage for non-US citizens, and those things are not covered by this scope by this community of practice. So it's important that we keep this frame in mind as you take in today's content, and also that you seek out additional content to support your learning and planning specific to those other policy elements. The National Council's HR1 Hub is a great place to access resources on all things HR1. We've just provided a link in the chat, so that's another place to go for more information. For this community of practice, we've organized our sessions around the coverage continuity intercept model that we introduced last session. So last month, we focused on the education side of this, the policy foundation of what we as providers really need to know and understand to position ourselves to help prevent coverage loss. If you missed that session, we will also post a link to that session in the chat. But today, we're going to work through the other activities associated with preventing and identifying by getting strong plans and workflows in place, identifying those impacted, and intervening once coverage is lost. The following month, session 4, next session, we will have a panel speaking to how to intervene and recover once coverage is lost. And then the following month, session 4, we'll focus on measuring the impact of how this policy has affected people and your organizations through strategies like key performance indicator tracking and story banking. We included the coverage continuity intercept model here as a reference, and we'll bring it up a few more times throughout this session, but we won't dive into it in detail here. But at a glance, you can see how it maps where people fall off the Medicaid rolls and intercepts where targeted action can keep them in. So we'll continue to use this model to frame our thinking around redeterminations. So my name is Katie Lipp, and I am a principal with Bowling Business Strategies. And we have partnered with the National Council to develop and facilitate this community of practice. BBS is a national behavioral health consulting firm based in Philly, and we specialize in helping behavioral health organizations translate policy and payment changes into actionable strategies, whether that means launching new services, redesigning workflows, or otherwise positioning organizations for long-term viability. So you can see how HR1 fits right in here. I have worked across the behavioral health system in direct service, administrative, applied research, and consulting roles, and really appreciate how changes like those that we will discuss today impact every facet and every role type within your organization. I also just want to acknowledge that there are so many policy changes competing for our attention right now, and it's heartening to see so many of you here today preparing to mitigate the impact of HR1 for people who rely on Medicaid coverage. So thanks for being here. Today's session gets into the practical application of the policy. We will provide a framework to identify clients most likely to be impacted, consider the supports that clients will need, and the staffing and reimbursement options to facilitate those supports. We'll introduce strategies to assess your workflows and consider the changes needed to best support your clients. We will also talk through some communication and outreach strategies. As a reminder, immediately following today's content, we will have some additional content for our practice transformation cohort. So if your organization was selected for the practice transformation cohort, please be sure to transition to the new link at the end of the hour. We've also reserved about 10-15 minutes for Q&A. So as questions come up for you, please feel free to use the Q&A feature to ask them, and we will address as many as possible, both throughout the hour, but also during our dedicated Q&A period out loud. So let's get into it. The first step organizations need to take is to identify clients impacted by HR1 redeterminations. First, and critically, not all individuals with Medicaid will be impacted by HR1. So as we talked through in our last session, these changes are really focused on the Medicaid expansion population. Among that population, there will be many who qualify for an exclusion or an exception, some who are already meeting the community engagement requirements, others who can get there with significant support, and still others who will lose coverage. At a high level, we can begin to think about these as client segments and then begin to think about the different approaches that each might need. To give you a sense of the scale of these segments, researchers in Colorado used a 2021 data set that compiled EHR data from a large medical system, state Medicaid, and other data sources to model how social and health factors that could potentially exempt from work requirements. And you can see that in this model, about a third of Medicaid beneficiaries were covered under expansion. So those are those dark blue people on the middle left of the page, leaving, and then just over half of those individuals met an exclusion or an exception. So that leaves just under half of the 1/3 on the hook for community engagement. Looking at the chart to the right, among those with factors that may indicate exclusion or exception, almost half were medically frail, and caregivers was the second highest exclusion category. Now, there are a few really important caveats to this case study. First, it's used diagnostic assumptions to categorize medically frail that may not align with state-specific operationalization of this category, and we'll get into that a little bit later. Secondly, this is a standard health center data set and not behavioral health specific. And so it's likely that your organizations will have a higher percentage of traditional Medicaid folks, as well as those who meet criteria for exemption. But just wanted to kind of use this as an example of what this might look like. So while the Colorado case study modeled who's likely to be impacted, it's more complex to model who of these client segments is likely to maintain coverage. And this is because there are two ways to think about potential disenrollment. There's procedural disenrollment and loss of eligibility. So procedural disenrollment happens when an individual loses coverage because they did not meet all of the procedural requirements related to redetermination. During the COVID era unwind, 2/3 of individuals who lost coverage were in this category. So it's really, really important that we pay attention to this. This can include situations like missing a renewal notice because your address changed, or not submitting the required verification documents. Under HR1, we anticipate that this category may grow to include folks who just don't even bother renewing because they know that they're not meeting community engagement requirements and therefore don't do it when really they would have potentially qualified for an exemption, for an exclusion or an exception. So really important that we think about these two different types of disenrollment. So, in thinking about your client segments, the first step is to identify who among your clientele is covered by Medicaid expansion. In some states, this is a super clear-cut process where individuals covered by expansion are really clearly identified as such in the online state Medicaid system or by their ID card. Maybe it has a different name on their ID card. In others, it's not. So, a quick little primer on Medicaid expansion. In all states, you can qualify for Medicaid based on income, household size, disability, family status, and other factors. Eligibility rules differ a bit between states, but this is what we refer to as traditional Medicaid. In states that have expanded Medicaid coverage, and we have a link here in our slides that will take you to a KFF map, you can qualify based on your income alone if it's within a certain bracket and you're between the ages of 19 and 64. So if you live in an expansion state and do not have clear line of sight on which of your clients are covered by Medicaid expansion, there's a couple of different options. The best option is to reach out to your state or MCOs and ask and see if there's a way to potentially share files, share enrollment, and flag those covered under expansion. If this is not possible, your second best option is to use some proxy measures to make educated guesses about who in your population is covered by Medicaid expansion. So what I would do in that situation is I would filter for all of my Medicaid beneficiaries who are between the ages of 19 and 64, who are not duly covered by Medicare, not covered by SSDI or SSI, and not pregnant or postpartum. This is not a perfect system, but it will give you an idea of who is likely in your expansion population. The next step, once you have a sense of who's in your expansion pop, is to further segment that expansion group. This segmentation will help your organization in your planning by helping to scope client support needs and overall projected impact on your organization financially, staffing wise, etc. but it also is likely will need to be incorporated into your ongoing operations as you figure out how to implement this policy. So we suggest three buckets. The first is those who are excluded from community engagement requirements or meet an exception. And we'll talk a little bit about what those are. The second is those who are currently meeting community engagement requirements. We'll also talk about what those are, and therefore likely to remain eligible for Medicaid at the time of their next REDI. And those remaining clients, the group three, who without intervention are likely to be identified as ineligible for Medicaid at their next redetermination. It's important to understand that even those who meet criteria for exclusions or exceptions, those in group one, are likely to be subject to 6-month redeterminations and therefore at higher risk for procedural disenrollment than current state. So really important that we're thinking about that piece as well. So as a reminder from our last session, individuals who meet criteria for most exclusions or exceptions should be identified by the state. This is not true of individuals who are claiming a short-term hardship exception due to inpatient treatment or medical travel, in which case the individual must initiate the process. But in all other situations, states are required to attempt to determine eligibility through data, which is a process referred to as ex parte. If eligibility cannot be determined ex parte, states must send a pre-populated renewal form requesting at least 30 days to return. Individuals must then submit additional verification documents to substantiate the exclusion or exception. Before we talk about these in further detail, I want to acknowledge that this is really dense and complicated, and everyone here is coming from a different place of exposure to this. It's going to take a lot of repetition to really understand these categories. And we have so much to share with you today that we're not going to spend time really getting into the nitty-gritty definitions for each of these groups. They will be available as an appendix to this deck. And there are certainly other resources that will go into more detail, but we're getting more into sort of the operationalization of it all. So HR1 outlines for whom community engagement rules apply, which individuals are excluded from these rules, and for whom there are exceptions. So on the top left, you see mandatory exceptions, which include those under age 19, those duly eligible for Medicare Parts A or B, eligible for traditional Medicaid, incarcerated in the last 3 months, and then those specified excluded individuals. As states build up their capacity to coordinate with data sources and otherwise manage this process in general, right, which involves staffing and workflows and other things, we anticipate that this process, this ex parte component, will be imperfect. So provider organizations will benefit from proactively sorting these groups to understand the scope of support that will be needed to maintain coverage. Those groups shown in orange are those that we think are most likely to require additional verification that won't be readily accessible to the state Medicaid office, at least initially. So this is just sort of our own applied thinking here. So we've highlighted incarcerated individuals, as most states don't have efficient connections with county facilities. So we anticipate that there will be some data blockage there. Looking to the group of excluded individuals, we anticipate that in two-parent households, it may be difficult to verify which parent is primary caregiver and thereby excluded from requirements. We've also highlighted participants in SED treatment as there are not yet clear operational procedures for how many hours of treatment an individual must receive per month to qualify, and that will be likely a state-specific decision. It's also important to remember here that for-profit treatment facilities will not qualify under this exclusion. It only refers to nonprofit. Medically frail is likely to apply to many individuals receiving community mental health services, as it includes among physical health categories those with a substance use disorder, except those in recovery for 5 years or more, and those with a disabling mental disorder. CMS has clarified that medical frailty cannot be determined by diagnosis alone, and that it needs to be about the impact of the condition on an individual's ability to comply with community engagement requirements. No states have yet released clear guidance on how this will be operationalized. So it could, for example, be based around like a functional impairment assessment. There could be other factors. So we're sort of waiting to see what that looks like. Moving to the bottom left of the slide, you'll see short-term hardship exceptions. These are optional for states, but those who choose to adopt them must adopt all of them. We have highlighted inpatient, institutional, and medical travel in orange, as both will require the individual to initiate the exception. And that's going to require significant documentation and tracking to verify. And again, that's going to be state specific. Um, so the receiving inpatient or institutional care will also include those who are receiving services of similar acuity, which includes IOP and PHP to the extent that it can be shown or otherwise communicated that by engaging with PHP or IOP, that person is avoiding a higher level of care. In many situations, these individuals would qualify for medically frail exclusion, which may be easier to verify. And we're going to talk a little bit about sort of how these things might layer on top of each other and the administrative burden associated with each. So to summarize the key points we just covered, you need to know that all folks are likely subject to 6-month redetermination, even when excluded or by exception. Medical frailties, it is not included in that, but we won't get into the nuances because let's stay on big picture here. States will likely require documentation to support verification for several groups beyond what they can accomplish ex parte. Documentation will vary by state, and the overall risk for procedural disenrollment because you didn't have all of the necessary paperwork, even though you remain eligible, is really high. Organizations like you all need to start planning now by understanding which of these data points you collect and which you can report on to support monitoring and outreach. The state may determine there to be insufficient documentation for a particular exclusion or exception. So let's say we can't prove medical frailty, but we can prove caregiver, right? So it's going to be really important for you to have visibility and awareness of all exclusions or exceptions that may apply to an individual, so that you can sort of make sure that you have backup plans and that you're also thinking as an organization about which of these are we able to best support with, and where is the administrative burden lowest if someone potentially qualifies for multiple. So you'll need to coordinate with your state to understand its specific requirements and any changes that your organization may need to make to support documentation, such as with medical frailty, how are we documenting the impact on one's ability to work? And you should also anticipate that there may be an increase in demand for services from new clients as individuals who have a disabling mental condition but have not been engaged in treatment may now seek treatment so that they can have that verified for the purposes of being excluded from community engagement requirements. So just another thing to be kind of thinking about and anticipating. In general, we expect that folks may need help identifying, organizing, keeping key documents safe. You will also need to build in processes to anticipate who is at highest risk for procedural disenrollment based on challenges with documentation and verification or communication, and target organizational resources appropriately. And we'll talk a little bit more about some different ways to think about that and where to put resources. So next we're focusing on this likely eligible group who is currently meeting community engagement requirements. And in our appendix, we specify the specific requirements for community engagement, but in general, there are 3 pathways. So folks who have a monthly income of at least $580, they are they're engaged in 80 hours or more per month of an educational program, or 80 hours per month in any combination of paid work, in kind, unpaid, community service, or a work program. There are some critical open questions related to community engagement. So, for example, how or if Medicaid covered employment services, so thinking about things like supported employment, psych rehab, peer support, whether any of those can be counted against any of these pathways, that's an open question. Furthermore, is there a role that organizations can play in creating community engagement opportunities for clients? I think the general consensus so far is that there's a lot of risk inherent in this, but I think this is still very much an open question and something that a lot of organizations are exploring. Again, provider organizations need to understand which of these data you collect, to what extent you can report on the data and make use of it. And individuals may need help identifying the documentation needed to verify their engagement. And you'll need to assess who's at highest risk for procedural disenrollment so that you can target resources accordingly. This last bucket is our non-excluded individuals who are not currently able to demonstrate having met community engagement requirements and do not meet criteria for an exception. This is a super critical segment for intervention because there's still time. We're in August right now. There's still time to support them in meeting community engagement requirements. That said, organizations need to consider their capacity on several fronts. So, this involves first assessing which individuals have a high potential for meeting requirements with some support. Who is almost there and could meet the requirements now that there's clear expectation from the feds and support from your team? What partnerships can you foster in your community to help folks to satisfy these requirements? And otherwise, who is at high clinical risk if services were to be discontinued? To what extent can your organization absorb the costs of uncompensated care for these folks? And I appreciate that that is a really loaded question. So now that we have an understanding of the process at a higher level, let's consider how to operationalize it. The first step is to map your workflows. It will be exponentially harder to make changes, communicate the changes, engage in continuous quality improvement, train your staff if you don't have the processes mapped in the first place. And as a consultant, we see this all the time. Most organizations don't have them written out. Um, and so you can write out, there's no one way to do this, right? You can write out your processes in a sequential process in Microsoft Word or Excel. You can use process maps in PowerPoint or Visio or external tools like Miro. It doesn't need to be fancy. You just need to lay out the steps of what things look like right now. You want to understand where, when, and by whom this data is currently being collected. Many individuals will meet criteria for multiple exclusions or exceptions, like we've talked about. And as you gain a better understanding of those that most impact your client population, combined with the administrative burden of demonstrating that the individual qualifies under your state's specific processes and protocols, you're likely to find that certain ones are easier for your organization to support verification of than others. And so you'll want to be able to run your reports in a way that flags all potential exclusions or exceptions. Then, once you have a clear understanding of current state, you can evaluate gaps. Which data is not being collected at all? Which do you have some line of sight on, but not with the same definitions as your state? And what other data could help inform your preparation? I want to be really clear that this is not ultimately on provider organizations to do, right? This is on the state. And if we don't engage in some way, then we don't have any opportunity to mitigate the impact of this policy change. So this is not a have to, this is really a should. And on the next slides, I'm going to show you two different ways that you can think about how to do this. So here we've mapped the data by process or like by client intercept to understand which information is captured. So starting first with the intake, we've mapped that we are capturing vocational status and hours worked. We're capturing income, insurance status. We're just sort of writing down which of the data elements that would be required to understand if they meet an exception or an exclusion we are capturing in that part of our engagement with the client. And then you see so on and so forth, right? Appointment registration, ongoing treatment, treatment plan updates. If I were taking this approach, my next steps would be to crosswalk each of these data definitions, so the way that we're capturing the data in our system, with the CMS and state definitions, and then the approximate cadence that we're collecting the data. As we find that there are certain components that aren't being asked at the right cadence or in the right way to give us the data we need, we can make adjustments. But maybe you decide not to even do that, right? Like, I guess similar to what I said just a few moments ago, you might decide that a proxy measure is good enough and that you might just use what you have to make guesses about exclusions or exceptions. This is really all just kind of food for thought as you think about what level of risk your organization is willing to tolerate, what level of support you can offer, and what sort of resources you have to put towards this effort. It's really important as you do this to be mindful of other contractual or regulatory requirements that govern these data points or frequencies. So for example, we don't want to match to the CMS or state definitions of an exclusion if it's a data point that we also need to be able to report on for a SAMHSA grant. So make sure that you're thinking about all of those things as you make adjustments. This is just another approach at how you could do this workflow mapping where we are mapping the data by data element. So here in the first column, we've listed out examples of data elements that we would need in order to understand exclusions or exceptions. We've mapped to where in the current process we're capturing this data, crosswalked it to the definition to understand gaps, and then laid out next steps that we could take. So, for example, perhaps we are currently assessing employment status via a drop down on the assessment and a functional impairment assessment, the ANSA, that we're completing quarterly. While this frequency is meeting our needs, it doesn't capture hours, which limits our ability to use this data element to approximate those who are actually meeting community engagement requirements. Again, we might say that this proxy is good enough, or we might want to drill down. So we plan to add hour specifiers to our quarterly process and then develop a companion report that can spit this out. We might also choose to do nothing and roll forward with this. So just want to show you all a couple of different ways that you could approach this. As we've been talking through this process, I imagine many of you have been thinking about how tech in general can be leveraged to support this process. We anticipate there'd be several places where EHR changes would be needed. So we have new fields to capture data elements that maybe you weren't capturing before, such as flags for folks who are covered by expansion, redetermination date. You might want registries that can pull client lists based on criteria that you define, such as by MCO. Maybe dashboards and reports, such as clients with a redetermination in the next 60 days, payer mix, so you can pay attention to the financial impact on your org, uncompensated care burden. We'll talk more about key performance indicators in our session 4, but you can start to see how this plays out. And maybe you want some smart phrases and templates to support documentation and outreach, like pre-populated client outreach letters, and potentially due date tracking for things like data collection, redeterminations, and appeals. Before we dive into the next section, I want to launch a poll where we can do just kind of a quick pulse check of where you all see yourselves now. I think, yeah, there we go. So you should be able to see the poll, and I'll give you all just a minute to complete. So our question here was, does your organization currently assess and document the extent to which their mental health condition or substance use disorder impacts ability to work? And again, we don't know how this is going to be defined just yet, but we know that it will be a requirement. And so far, we're seeing about a fifth to a quarter of you feel like, yes, we're assessing and documenting this at least twice per year, which is, was deliberately written in that way because that would support the REDI process. Partially, so we do this, but maybe not in a standardized way or at the frequency that would be needed to really be able to provide verification for this exclusion. And then about a third of you do not assess this right now as a part of your regular workflow. So thank you all. I'm going to keep us moving here. All right. So let's get into client support strategies, the types of support that clients might need to maintain coverage. So big picture, there are a number of ways that you can provide broad-based support to your clients to maintain coverage. One approach is to shift coverage. So there may be clients that would qualify for traditional Medicaid that are currently covered under Medicaid expansion. And if we can help them transition in, then they can avoid all of these new requirements associated with HR1 altogether. That's probably not a huge group, but it might make a difference. More generally, there may be opportunities to increase coordination with Medicaid and the MCOs. Some proven strategies include adding releases of information to the state into your intake and annual paperwork packets, or standardizing requests to access the online state portal on a client's behalf. Another one is bidirectional sharing of rosters. So you share your client list of folks covered under this insurance, and then they can send you something back with, redetermination dates. HR1, of course, necessitates more documentation at a more frequent cadence. So there may be opportunities to organize these documents through a state-run or organization-run documentation hub, or attached to like a statewide care coordination platform for states that might have that rolling. If this is something that your organization or your state has already been working towards, think of HR1 as the catalyst and make it happen. One key piece of feedback that we're hearing from early implementers in Nebraska is to really focus on keeping clients engaged. They're talking about that really being like the key to staying in touch with folks. So increased focus on rapport building and more frequent opportunities for a connection is a great way to keep communication flowing and mitigate the potential for loss of coverage. And lastly, one thing I've been curious about is the potential for aligning agency documentation with the individual's redetermination schedule as a way to ensure that changes in clinical status that would be needed as verification in the RED process are documented and ready to go. So, what that could look like, and I appreciate that this is like an enormous to do, and so we'll see whether or not this ends up feeling needed, but potentially making it so that your 90-day treatment plan updates um, are in alignment with the individual's redeterminations. So looking at what these continuity tasks might look like, I want to first emphasize that this is not new work, right? It's certainly more frequent, and in some cases maybe more intensive or spread across a broader population of individuals that might currently be getting this type of support, but it's not new. Supporting continuity of coverage involves making sure that any changes to things like address, income, household, or similar factors are documented in your agency system and updated with this in the state system. It means ensuring folks have an online account with Medicaid so that you can make those updates and also be able to provide more of a monitoring function. Monitoring for communication from Medicaid, and more importantly, checking for understanding, helping folks develop tracking and organization systems across their broad team of service providers and supports, tracking down verification documents and submitting paperwork, coaching through in-person or phone meetings, helping individuals get to the Medicaid office or to other facilities where they need to pick up paperwork, knowing when legal aid is needed and facilitating that referral, which we'll get into next session, and identifying and coordinating bridge supports in the case of a loss of coverage, which we'll also talk about next session. This is certainly not an exhaustive list. And these tasks are written broadly. They'll be much more granular depending on the specifics of the individual's situation. For example, someone who is meeting community engagement requirements through paid work, you would want to add in here tracking pay stubs, right? Someone who meets criteria for medical frailty as an exclusion will need help verifying that their condition impairs their ability to work. But regardless, this understanding of what these support tasks might look like helps us to consider who might need what types of support, which of our staff are best suited and available to provide that support, and which activities might be reimbursable under the existing care plan. So let's talk about that. First, who might do this work? Thinking about this purely from the standpoint of scope of the different roles in your org, we've outlined which role types might be best suited for which activities. So intake staff, through their existing processes, will set the foundation by helping identify the members of the care team, ensure ROIs are signed, and records are requested, and assessing the person's needs in a comprehensive way. The front desk will send appointment reminders to help maintain engagement. They will track updates to things like phone number or address, and they will verify eligibility prior to each appointment, which may be, for folks who aren't proactively communicating, the only way that we find out that their Medicaid has been turned off. Peers will help keep the individual engaged with the team by identifying barriers and preferences and providing support at appointments and in the community, such as at the Medicaid office or maybe at the site where the individual is completing community service. The case manager will continuously assess and monitor across all domains, flagging new needs, documenting updates, and coordinating across the team, both within the org and outside of the org. One of the things that I'm concerned about looking ahead to HR1 being implemented is we have such limited resources across our continuum, across our system of care, and the last thing we need is for folks to be duplicating one another's efforts. So I really see the case manager as playing a critical role in understanding who's going to be taking on which tasks. The clinician will provide the diagnostic assessment that might flag an individual for an exclusion. Again, it wouldn't verify a medical frailty or substance use, a medical frailty exclusion, but it might flag them for one. They will potentially assess functional impairment, which in some states might be the verification needed, and identify the need for additional supports or services via the care plan. The clinician will also treat symptoms that might otherwise hinder the individual's ability to engage in the community or in the redetermination process, like amotivation or anxiety. And then the psychiatrist will also help treat those symptoms as needed pharmacologically and is likely assessing or at least signing off on the documentation of medical frailty. Lastly, administration should be meeting with the state, MCOs, FQHCs, and other key partners to understand each entity's role and approach to continuity of coverage and really make sure that we're maintaining collaboration throughout this process. This is another great place to map out your workflows to understand current state and prepare to document changes that will be needed in who's doing what across your org. Okay, so each of the buckets that we previously identified is likely to have really different support needs, which may require different agency resources. Our first group, those who we expect will be excluded from community engagement requirements or otherwise qualify for an exception, should remain eligible for Medicaid, right? But they may need support to avoid procedural disenrollment. So, support gathering requested verification documents, monitoring communications. Group 2 is currently meeting community engagement requirements and therefore should remain eligible for Medicaid, but they may need support collecting the necessary documentation that verifies their community engagement. It will be particularly important to understand your state's requirements around this, ensuring that they're using the correct forms, the right units of measurement, getting the right signatures. And our third group, those who are likely eligible for Medicaid at redetermination those who are likely ineligible for Medicaid at redetermination, as they're not excluded, they're not currently meeting community engagement requirements, and they're not currently meeting an exception, will need help getting connected to community engagement activities to increase the likelihood that they'll be able to get there within the period of time necessary to fulfill the look back period. These individuals will also need support developing contingency plans should they lose coverage. On the bottom of the slide, we have linked a resource from KFF that outlines several hypothetical scenarios that I think really helps to illustrate how this will look with real people, and encourage you all to check it out as you work through your own scenario planning. So with your population segmented and a clear sense of the types of needs of each segment, there's now an opportunity to consider which supports might be provided under the current care plan by members of the existing care team. One approach to this might be to review the list of continuity tasks we discussed previously, identify which of them the client needs, and map them to the treatment plan. A few points of caution here. We are intentionally not discussing each of these in detail because they are defined differently under each state's Medicaid state plan. Be sure that you're clear on how the service is defined and any documentation requirements within your state before attempting to bill for continuity tasks under these services. We also wanted to flag the temptation to work backwards from the approach that I just laid out by first identifying the individual's continuity needs and writing them into the treatment plan. I think we need to be really careful that the services that we're providing as a part of the continuity support are medically necessary as a function of the individual's diagnosis before we seek reimbursement for those tasks. I'm sure that there are additional services that have been omitted from this list. You see on the bottom right, we left a what else. And if you have additional ideas, please let us know. These are the ones that come to mind for us that would at least bucket a few of the tasks each that we talked through. And some of them really could cover them all. This slide offers some considerations for how you might think about risk. So there are those who are at high risk of loss of eligibility, those at high risk for procedural disenrollment, and those at high risk should their access to care be impacted by loss of coverage. I would love to be able to provide an algorithm that helps you think through exactly how to calculate these risks. But the reality is, this is an organization specific decision. And the reason for that is because there are also organizational level risks to consider. There's the moral and reputational need imperative to care for individuals that have really high needs. There's the compliance imperative to make sure that we're adhering to state and federal requirements and not, for example, seeing a significant change in the acuity of our client population once HR1 rolls out, right? There's the fiscal imperative to be good stewards of our resources and to keep our doors open. and remain available to the community. And then there's the need to really consider the administrative burden and the impact on staff well-being and retention. And I know these are all things you grapple with every single day. And I also know that you know that these are sometimes competing priorities. So, for example, targeting resources to those at highest risk of disenrollment is important. And we might also want to think about who's most likely to be able to get back onto Medicaid. So, for example, a single 30-year-old man with no job is probably at highest risk of disenrollment, but to help him get coverage might be really resource intensive, right? We might be working really hard with him on job skills training and placement. Whereas a mother of dependent children who just needs help getting some documentation cleaned up because she's at risk of procedural disenrollment is going to take far less resource from our organization. So let's think through that a little bit more strategically. So continuity pathways offer you an opportunity to operationalize your risk calculations and strategically allocate resources to those who have continuity support needs that cannot be met by the existing care team. So what we suggest is stratifying these folks by the level of clinical risk and the likelihood of maintaining coverage with staff support. From here, you can develop continuity pathways for each group that clearly outline how staff should respond and to what extent external care partners need to be pulled in to provide support. So the care pathways that we've listed here with like the bullets are just suggestions of what this could look like. So let's talk through those suggestions. As an example, at my organization, perhaps we decide that for those that have a high clinical risk but a low likelihood of maintaining coverage, even with extensive staff support, we're going to reserve our staff support resources for other clients and instead absorb the costs of the uncompensated care provided to this group. Again, this is not what you should do. This is just a way to think about things. Conversely, for those with high clinical needs in that top right-hand corner that we see as having a high likelihood of maintaining coverage, we might hedge our bets and provide intensive supports to maintain coverage. Moving down to the lower left-hand corner of low risk, low likelihood of maintaining coverage, this might be a group that we really lean on our partners. We rely on the MCOs or perhaps an organization that is more serving as their health home. So perhaps an FQHC if it's somebody who has high physical health needs to provide that support. And then in that bottom low risk, high likelihood, this is a place where we might offer minimal support if we have the resources to see if we can help them get over the finish line. So just a framework to help you think through your own strategy here. Earlier, I talked about administration's role to coordinate with care partners. And on the last slide, we talked about the need to leverage partners to support access for clients who are considered lower risk. And here we've outlined what this coordination might look like at each of the key intercepts in our CCIM framework. So at intercept 0, we encourage you to work with community-based orgs, MCOs, housing providers, schools, faith-based organizations, to help make sure that everyone's working from the same knowledge base, is aware of one another's plans regarding outreach and support, and coordinate tracking and data sharing. This is a great place for a RACI. At Intercept 1, where the client has received their renewal notice, you might shift to working with state vendors, case managers, care coordinators, and community health workers to share state policy and procedure updates, individual level notices and updates, and otherwise coordinate efforts to support redetermination. As we move to Intercept 2, we might focus on partnering with pharmacies, hospitals, EDs, crisis services, legal aid, because now we're talking about bridging the gap during a coverage loss. At Intercept 3, you might coordinate with Medicaid staff, MCOs, or navigators to recover Medicaid or explore alternative coverage. And then at Intercept 4, you're really pulling together all of these partners to improve upon the previous process and already start preparing for the next redetermination. Because remember, it's coming every 6 months now. So perhaps the highest risk and opportunity in the operationalization of HR1 redeterminations is communication. Without it, individuals are at tremendous risk of procedural disenrollment and loss of access to care. So we need to be really strategic about how and when we communicate with clients. As key context, you should be aware of what the state is required to communicate. Prior to implementation, states and or MCOs are required to outreach via mail and one other modality. So that can be phone, text, things like that at 2 points. So 3 months prior to the implementation date plus the state look back period, and then again before implementation. So for states implementing in January with a 1 month look back period, this means that the initial outreach will happen next month in September. And then there will be a second outreach somewhere in October, November, December. After implementation, states are required to outreach enrolled beneficiaries on an ongoing basis with the CMS defined events. So, change in individual status or upcoming redetermination. During the redetermination process, if the state is unable to verify exclusion or exception ex parte, they must send the beneficiary a pre-populated form, giving them no less than 30 days to respond. So, when thinking through your communications plan, there are a few key concepts to keep in mind, as outlined in Colorado's communication toolkit that we have linked here on the bottom of the slide. Outreach and communications should be layered across phone, text, portal, EHR, and in person touchpoints, and with repeat cadence at key intervals and milestones. This might include flyers, slides, talking points for your staff or partners, mailers, texts, or a one pager that's posted at check in. Client-facing communications should repeat key messages to really reinforce the concepts that are most important to understand. So from my perspective, that's keep contact information updated, keep watch for notices, and let your team know of any notices received. Communication should also be separately targeted to staff and partners. Universal posts, which are those that use the same image and caption across formats like Instagram, LinkedIn, Facebook, newsletters, can be a great way to maximize reach and use resources efficiently. And perhaps most importantly, we need to ensure that the materials can be understood by their target audience. I imagine many of you have been sitting here overwhelmed by the complexity of this content. And so we need to ensure that we're using plain language, matched to the reading level of your population, translated to common languages in your catchment, and reviewed by a client advisory board whenever possible. So here we've mapped how this might be applied across the CCIM framework with consideration for key milestones and timing. So prior to renewal, communication is broad, focused on monitoring for state notices and updating contact info. But after receipt of renewal, the outreach shifts to making sure people understand what they're getting. We're talking through support needs, and we're monitoring their progress towards completing that redetermination. In the case of loss of coverage, we are shifting our outreach again to ensuring that they understand the implications and helping them access alternative resources. And then as we move towards re-enrollment, we continue to monitor for those coverage notices. We help the individual access those alternative resources. And then finally, we're stabilized. We're already looking ahead to that next READY cycle. So you can see that monitoring for state notices and checking for understanding are really consistent outreach tasks across all intercepts. Okay, so that brings us to the end of today's content. And before we move into Q&A, we have just a few quick announcements. First, we ask that you please complete the session evaluation so that we can tailor our support to best meet your needs. There's a QR code posted on here, also a link, and the link will get posted in the chat. We also hope that you'll join us for our next session, which will be held on Tuesday, September 15th. We'll have a panel-style discussion focused on the intervention intercept, and we will be joined by representatives from a behavioral health organization in an early adopter state, a medical legal partnership, MCO, and benefit specialist. So please register and share as you see appropriate. We would love to have you. And with that, we have just over 10 minutes for some Q&A. So I know Taylor has been monitoring our questions. Taylor, are there any questions we want to share with the group?
Yeah, the first question in the Q&A is, will people with Medicaid receive communication about these changes? When and what form? Email, phone, etc.
Yes. So hopefully that question got answered in one of our later slides, but the answer is yes. So folks will receive notification at least 2 times before implementation, once 3 months before, plus the state look back period, which can be anywhere between 1 and 3 months, which means that they would be receiving it anywhere from 6 to 7 months, nope, from 6 to 4 months before implementation, and then they'll receive additional notices as they are nearing redetermination. So that's like the key message, is that we need to be making sure that folks are keeping an eye out for these, that they know not to just throw them away. They know that they're real. And that might occur via phone, text, mail, or otherwise. So their contact information also really needs to be kept up to date.
The next question in the Q&A is, if an organization exclusively serves children, how will the HR1 changes affect a child's medical assistance coverage when their parent or caregiver is impacted by the new requirements or loses their own coverage?
Mm. So that's a really great question. Theoretically, it should not impact children. Some early monitoring has shown that there are children dropping off the Medicaid rolls that seem to be more than just than like our standard ebb and flow. So children are not included in the Medicaid expansion population, and so they would be covered traditionally. And so that's why I say theoretically they shouldn't be impacted. So even if a parent does not complete their own redetermination for the expansion component, the child shouldn't be impacted. Um, Taylor, I don't know if you have anything to add to that.
I would note that in a lot of situations, when a parent loses coverage, the child also loses coverage just because of how systems are set up. So I think it's important to be proactive and making sure you have documentation that someone is a caregiver. And if you're a parent that your child is under the age of 13, then you would not be subject to the work requirements, but making sure you have the proper documentation for those parents is really important.
Yes, yes, thank you. And we didn't get into this, it's in the definitions, but a caregiver applies both to caregivers of a child 13 and under, but also of somebody who has a disability.
Another question in the chat is, if a state is not a Medicaid expansion state, will we be less likely to be impacted since they did not have any requirements before?
Yes. So when it comes to, again, like putting the frame around this community of practice, folks who are not part of a Medicaid expansion state won't be impacted by this redetermination process. There are some other components to HR1 that will impact those states. And then, Taylor, you can probably speak to this in more detail, but am I right in thinking there's maybe two states that aren't technically expansion states but have sort of similar processes and
Yes.
therefore are impacted by this?
Both Georgia and Wisconsin have partial expansion waivers, so they would be subject to this, but it would not be relevant to states that have not expanded Medicaid, which is only about 10 states left in the US.
Thank you.
I also will note that although the work requirements and eligibility redeterminations will not impact non-expansion states, it will impact some states related to provider taxes and state-directed payments. So although these states, people will not have to change their Medicaid eligibility paperwork, the states will also have some financing challenges related to this law as well. Um, and we've also had a few questions in the chat that are, can both parents be considered a caregiver or only one parent for the work requirements exemptions?
That is just whoever's identifying as the primary caregiver.
And then another question was, how are states thinking about criteria for functional impairment and documentation of impairment? And any examples from early adopters, such as Nebraska?
So I am also dying to find this out. I've been trying to keep my ear to the streets and really haven't heard anything. So I don't know, Taylor. I know that you guys in the policy shop are monitoring this really closely. You might have more intel, but I have heard nothing. Nothing has been publicly, formally distributed.
Nebraska has a list of their specific codes that they are using for the work requirements exemptions, but they haven't been very forthcoming about what counts as being functionally impaired for these codes. So we're kind of still waiting for a lot of information from a lot of states regarding implementation of this rule.
Yeah, I
And as
concur.
we said earlier, I think that there are some there I anticipate that there may be folks that come seeking verification specifically. And so how that plays out. I mean, if you're there's one thing to be doing this for the clients that are already your clients, and then there will be a whole nother cohort of people out there who are not currently tied to treatment who will need to find somebody to kind of verify their paperwork. And I think that that's going to be an like added layer on here.
And then another question in the chat is, what documentation would we need to have on file to prove someone is a parent to someone under 13 or is caring for someone who is disabled? So if someone is diagnosed with a substance use disorder, they do not actively need to be in treatment to qualify for an exemption.
Wait, was that two questions?
Yeah, sorry.
Okay. Okay. So the first one, my assumption here is that this will be verified ex parte because it will be they already have to detail their household composition in their Medicaid enrollment forms. And so I think that the piece that's going to be more complicated, and I don't know how states are going to operationalize this, is which parent is identifying as the primary caregiver and therefore eligible for the exclusion. Anything to add to that, National
I
Council?
would I would say for the when you're diagnosed with a substance use disorder, you are considered to have that. You do not actively need to be in treatment to qualify for an exemption, but you also may have to meet specific time criteria. If you were diagnosed with a substance use disorder within the last 5 years, you are exempt, but not greater than that. And states have not really defined yet how they determine recovery from a substance use, but it's important to note that that'll vary by state as well.
And that substance use disorder is bound to that same the same additional criteria as the disabling mental condition where it needs to
Mhm.
impair the individual's ability to work.
And another question in the chat is, can psych rehab slash IPS suffice as a work requirement? Currently, based on the CMS work requirements, IFC, it's based that they cannot count psych rehab or IPS if it's considered a billable service. If it is considered a service that people bill for Medicaid, it would not be part of the Medicaid work requirements. Hmm. Katie, another question in the chat is for two-parent households with multiple kids, should each parent try to claim primary for one child?
So I think that this is going to come down to this makes me think a little bit about the medical travel. Just because similarly, like the way that one works is if you're one caregiver who is traveling with your child out of state because they need some procedure that they can't get in state, and then the other caregivers back home didn't go but had to handle a lot of logistics to support that, they could potentially still claim medical travel. And I guess I think about this similarly, and I don't know again how states will approach this, but when I just think about it logically, if it could be demonstrated in some way that both parents need to play some sort of primary caregiver role because of the logistics of how their household runs, I think that there's a possibility, and I think it would be very difficult to verify, and it will be very dependent on state specific operationalization.
Mhm. I think we have time for one last question.
Let's
So,
do it.
similar to the SNAP letters we can submit for the work requirements, would a letter from a clinician work for the exemption for medical frailty?
TBD. So I think we're really just waiting for state specific guidance on that. They have we are expecting it anytime. This is like the biggest question, and providers are going to need time to respond and build in processes to support. So I appreciate the angst and the frustration with not knowing the answer, and we don't know the answer. So um, thank you all, and thank you, Taylor. I know that was a lot of questions to sift through. We so appreciate you joining us today. Hope to see you all next month. And again, another reminder that if you are in our practice transformation cohort, please hop on the other link that should be in your calendars. Thanks, everybody.